In this module, we're going to explore two themes: medical knowledge for healthcare interpreters, focusing on the topic of pain, and cultural knowledge for healthcare interpreters. But before we begin, I want to reiterate why it is important for healthcare interpreters to learn and understand general concepts in medicine. Previously, we said that being familiar with common medical concepts would make it possible for interpreters to use their anticipation skills. Anticipation skills can help interpreters predict what might be said or discussed by the participants in an encounter, giving the interpreter time to prepare with the vocabulary they may have to interpret. Anticipation skills help us interpret faster because it speeds up the process for language transfer, especially if we can anticipate a message because we have interpreted its meaning before. Transferring and reformulating the message into the LOS is going to be much easier. But even if we have never interpreted a concept before, for example, let's say we have never interpreted for a patient who has had an MRI, but you have had an MRI yourself, that experience may help you anticipate a message. You may know, for example, that the patient will be told not to move during the MRI because the movement can distort the image. In this case, even if you have not interpreted, if you can recall it and anticipate it based on your background knowledge, it most likely means you understand it, so you can cut down on the time it takes to extract the meaning in order to interpret it. We also said that anticipation skills make it easier to memorize a message, which helps us with our accuracy. Of course, you also heard me warn that anticipation skills are meant to assist interpreters with accuracy and completeness. So, we should never get ahead of the speaker. For example, if you are interpreting during an encounter where the provider is explaining a procedure to a patient, even though you may be familiar with the explanation, you may even be able to give the explanation without the provider there, you are still responsible for interpreting everything that is said without adding anything, leaving anything out, or changing anything said by the speakers. So, if someone did not say something, you do not add it to the message, even if you're sure they will say it later on. If someone has phrased a message differently than how you have heard it before, you have to phrase it the way that speaker that you are currently interpreting for has phrased it. And remember, as you begin to practice interpreting, whether in class or in the field, you will build knowledge of medical concepts to strengthen your anticipation skills. But be sure to use them to make you a better interpreter and not to step outside of your role or boundaries. In this course, we will learn about common illnesses and medical conditions, the common symptoms and signs associated with each, as well as common risk factors, ways to diagnose and treat them, specifically to help develop your knowledge of medical terminology and general knowledge. This week, in addition to the vocabulary list or lists, we are going to practice some common evaluation and screening questions that have to do with our main topic, which is pain, which means we'll work on building our knowledge of medical terminology, as well as become familiar with some of the processes in a clinical setting to assist us with those anticipation skills. The assessment and management of pain is a top priority for healthcare providers because pain is the most common reason patients visit a healthcare provider. So as you can imagine, pain assessment is a topic you will be interpreting almost at every medical encounter. Let's do a little brainstorming activity. I'm going to give you 15 seconds and I'd like you to write as many terms as you can think of related to the topic of pain. Just any words that you think of when you think of this topic. Okay, and now I'd like you to take the same amount of time to think about some questions a provider might ask someone who says they are in pain. So of course it is important for interpreters to be familiar with pain terminology, words, for example, that describe pain. But interpreters should also know that a comprehensive pain assessment includes asking the patient how the pain impacts their life, including how it affects their mental and emotional health, and their views on pain, which may be influenced by the patient's culture. In the U.S. healthcare system, the WILDA pain assessment template is used to guide providers through the process of assessing a patient's pain. The WILDA pain assessment encourages providers to focus on the patient's words to describe pain and the words they use to describe the pain's intensity, the location and duration of the pain, and on the aggravating or alleviating factors, which means that you will be interpreting words that describe pain, intensity, anatomy, body function, movement, clinical, cultural, and homeopathic approaches to pain relief, and just plain old general vocabulary, especially since pain assessment usually begins with an open-ended inquiry. Doctors will ask questions like, "Tell me about your pain." And they do this because it allows the patient to tell their story and what aspect of the pain they find most problematic. For example, the pain may make it hard to sleep, work, drive, etc. And you will see that patients in pain want to tell their stories, and clinicians need to take time to listen to those stories because these stories provide meaning that shape how patients are cared for. Storytelling also gives the provider an insight into how the pain affects the patient's life. So here's where it is important that interpreters are able to remain transparent and allow the provider and the patient to connect directly and to be complete. If a patient is going on and giving a long story, the interpreter should interpret everything completely. Now, in some cases, if the patient is getting off track, or the patient is going too long, or for whatever reason, a provider may choose to redirect or refocus the patient. But an interpreter should never, on their own, decide to interject to ask the patient to stick to a certain type of answer, shorten their answer, or in any way disrupt the patients as they deliver their answer. Okay, so now let's start building our vocabulary. To guide us and help us build a terminology list, we are going to go through a common process used by healthcare providers to help them address everything in the WILDA template. The mnemonic OPQRST for pain assessment is used as a guide to gather the information needed to assess a patient who is experiencing pain. So this mnemonic guides the provider on what questions they should ask, which means these are going to be the types of questions you will be interpreting. So, O is for onset. Onset means beginning, commencement, or the start of something. So the information the provider is trying to gather with this question is, when did the pain begin? Or how did it begin? So you will hear them ask questions like, did your pain start suddenly or gradually? Was the pain mild at first and gradually got worse? What were you doing when the pain started? The P stands for provokes or palliates. I happen to think that they use these words because they fit the OPQRST mnemonic, but basically what provoke means is what aggravates or what exacerbates, what makes the pain worse is what we're basically asking. And what palliates is what makes it better or what improves it. So the type of question they will ask is, what makes your pain better or worse? Does anything make the pain better? Does anything make the pain worse? Does anything help with the pain? Does anything help reduce the pain? Now, as I'm going through these questions, I'd like you to think about how you would interpret them. And it's okay to stop or pause the video to think about that. Okay, moving down the mnemonic, we are at Q, and Q stands for quality. And what this means is, what does the pain feel like? So you'll hear questions like, what does the pain feel like? What words would you use to describe your pain? How would you describe the pain? Is your pain sharp or dull? Now, this question is a question that most interpreters dislike, because although we could possibly come up with the words for sharp and dull in our language, in this context, they're not words that we usually use commonly to describe pain. And healthcare providers also dislike using this question because it ties the patient into only two choices. And it's basically telling the patient, here are the two words that I came up with, which one would you select? Instead of allowing the patient to use their own words to describe it. But you are still going to have to learn these words because there are times when providers will use them, or they will be also used in questionnaires about pain. All right, and next is R for region and radiating pain. So region and radiation, what we're talking about here, what we're trying to find out is, where is the pain? And is the pain localized to only one area, or does it spread? So radiating pain is pain that begins in one area or region and spreads to other parts of the body. For example, let's look at an example of a person with knee pain. So a person with knee pain may have pain that starts at the knee, but may radiate down the leg toward the ankle, or upward toward the thigh or the hip, or to the back of the knee. So the pain starts at the knee, but it also spreads. That means that it is radiating, or it may not radiate. For example, a patient might say, no, it does not spread to anywhere else, or it does not radiate. It's only on my knee. So to gather this information, you'll hear questions like, does the pain radiate? Although providers are discouraged from using the word radiate because, again, it's not a common word that we use in every day. But you will hear some providers who still use it. Does the pain spread from where it starts? Where does the pain begin? Where is the pain the strongest? Do you feel the pain in the surrounding areas? Is the pain centralized to the area, or does it spread? The next one is S for severity. And when we're talking about severity, usually they use a numeric pain scale or numeric pain rating scale, which you see here on the screen. Most of the times they'll ask a patient on a scale of 0 to 10. 0 means no pain. 10 is the worst pain you can imagine. How would you rate your pain? That's what you will see most of the times. If patients are having trouble with the pain scale, a lot of times you'll also hear them modify it to ask, would you describe your pain as mild, moderate, or severe? On the screen, you also see those faces with the expressions. A lot of times when providers are working with children or with patients who don't speak English and an interpreter is not there immediately, they will use these faces to ask about pain. The types of things you will be interpreting are, first, the explanation of the assessment tool. So on a scale of 0 to 10, 0 means you have no pain, and 10 is the worst pain you can imagine or the worst pain you have ever experienced, how would you rate your pain? Or what number is your pain? How would you describe your pain? Is it mild, moderate, or severe? These particular assessment tools or assessment scales happen to have been translated in many languages. So I'd like you to open up the file, the pain assessment scales in your language of service, so that you can practice the terminology that is used here, as well as using the explanation of the scale from 0 to 10. And finally, the T in OPQRST is for time or duration. So these questions are meant to understand when the pain started, how long ago it started, or how long it lasts. So questions you might hear a provider ask are, when did the pain start? How long have you had the pain? Do you always have the pain? Is the pain always there? Is the pain constant, or does it come and go? Does the pain get worse during the day or at night, or is it always the same? And sometimes they'll also tack on to this question, have you ever had this kind of pain before? Okay, so I'd like you to take a moment to try to interpret some of the sentences you heard me say here, but also review the pain scales that are available for you in your language of service. But before I finish this video, we're also going to talk about 3 terms used to classify pain. So we're going to look at chronic, acute, and referred pain. Let's start by defining chronic pain. So chronic pain is pain that worsens and intensifies, so gets more intense over time, and that lasts or persists for months, sometimes years, or even a lifetime. Usually, a pain is classified as chronic if the pain lasts for more than 3 to 6 months. Chronic pain tends to accompany disease processes such as cancer, arthritis, fibromyalgia. So what I mean is that chronic pain tends to be caused by a disease process. But chronic pain is sometimes also caused by an unresolved injury. So an injury that might take a long time to get better. Chronic pain can also produce other physical conditions like tense muscles, limited ability to move around, or make it difficult to move around, lack of energy, and changes in appetite. And chronic pain is such a big problem because it can even cause emotional effects that include depression, anger, anxiety, fear of doing certain activities because the person is afraid they might re-injure themselves. These kinds of things sometimes make it difficult for a person to return to not only leisure activities, things like the activities they might have liked to do before, but sometimes even their job. It can make it difficult to return to work. Now, acute pain is another classification of pain. Acute pain might be mild and last just a moment, or it might be severe and last for weeks or months. But a pain is classified as acute if it does not last longer than 6 months, and it disappears when an underlying cause has been treated or has healed. Usually acute pain comes on suddenly. A lot of times it's sharp, very strong. For example, things that can cause acute pain include surgeries, broken bones, dental work, burns or cuts, labor and childbirth, and sprains. And the last class of pain that we're going to talk about today is going to be referred pain. So referred pain is pain that you feel in a location other than where the pain actually originates from. So in a place other than where the problem actually is. And the reason for this is because of the interconnection that exists between our sensory nerves and the way that they supply our different tissues. So let me give you an example of referred pain. One of the first symptoms of a heart attack is jaw pain, right? Pain around the teeth and jaw, even though the problem is with the heart. This is a classic example of referred pain, which is felt distant from where the heart actually is. Now in this picture, I'm not sure if you can see it very well, but this is known as a referred pain map, or a map of referred pain. This is a tool that is used sometimes in teaching. Now, referred pain usually occurs with what is known as visceral pain. And visceral pain is what we call pain that occurs when an internal organ is inflamed, diseased, damaged, or injured. So visceral pain is pain that is due to an issue with an internal organ. So let's take a look at some of these sites for referred pain. So for example, the heart is located approximately around here, but all of this area, if we're using this map, all of this red area is where someone might feel pain if there is an issue with the heart. So it's not necessarily only here, but a person can actually feel pain all over here on the shoulder, down the arm, that actually is due to an issue with the heart. The liver and gallbladder, as you see, is located around here, but you can see that the pain is actually felt over in the back of the shoulder, all the way up to the neck, the front of the shoulder, or around the area where it actually is. And actually, a lot of times, the most common sign of a gallbladder issue is actually pain in the back right shoulder. Our kidneys are actually up here because they are protected by our ribs, right? But most of the time when someone has pain that is due to kidney issues, they actually feel it down towards their lower back, right? All the way down to their thighs, either in the back or the front, with the most common location being pain in the lower back. So that is what we call referred pain. So what I'd like you to do now is I'd like you to watch the 2 videos that I have posted on this page. And I'd like you to pay attention to how both this doctor and nurse talk about pain assessment and what's important for the provider to understand about someone's pain. I gave you a little bit of a brief overview about why they ask these questions, but I'd like you to listen to it from a healthcare provider's perspective so that you can see what kind of information they are trying to gather and how important that information is. I'm going to then ask you in the next assignment to actually write down a sort of scenario using those questions so that you can practice using those questions and practice interpreting some of those anticipated answers we might hear from a patient.